We have two presenters this morning, Dr. Verina Waights and Parvathy Harilal. Thank you. And they're going to be talking about digital literacy, digital health literacy. And I don't know about yourselves with the discussions that we've had over the last couple of days, but this is certainly an area that needs to be looked at and seems to be becoming more popular. So I'll be timekeeping, and I'd like to welcome our first speaker, Verina. If you'd like to come up.
Thank you, Hannah. Oh, my voice isn't very good today. I'm affected by the rapeseed, so apologies. But hopefully the slides will do most of the talking, I think, this morning. So why do we think digital health literacy is so important? Primarily, it's because there's such an increasing demand on our services. We know that general practice is struggling, that our district nursing services are under great pressure, so are our mental health services. And we've also got the problem that we have delayed discharge of medically fit people, particularly older people, in our hospitals because we're not able to get them the care package that they need to be able to go home safely after they've been admitted. We also have financial constraints on services. We all know about the increasing ageing profile and the rise in the population living with long-term illness. But we've also got the issues around the ratio of working age people to retirees is estimated by 2020 to fall from 4.1 to 2.1. It's also estimated that by 2030, we're going to have an 18 million shortfall in healthcare workers worldwide, which actually is over twice the 7 million shortfall that was estimated in 2013. And the EU have estimated that by 2025, we're going to need an additional 20 million family carers, which is really high and means that really most of people of working age would need to be in some kind of caring situation, which clearly is not going to be the case. So many initiatives see digital technologies as the way forward for improving healthcare. That ICT and telemedicine in Europe is estimated to improve healthcare efficiency by 20%. Telehealth care and is increasing. There's more public services available online. And we've heard over the last couple of days about the massive increase in health apps that encourage healthy lifestyle and self-management of health. And at the moment, there's over 100,000 apps on the market. And there's an example here. The NHS has started approving apps. So have you any idea how many apps they've approved to date? Anybody, any ideas? 5. It's actually 1. So there's 1 approved and a couple being tested. So we have a very long way to go of encouraging healthcare professionals to have confidence in these apps, and then by knock on the general public, it's a very, very slow process. So some of the initiatives are telemonitoring in homes, in text messaging from GP surgeries. In Florence, Italy, there's 70 healthcare authorities linking with text messaging to 22,000 patients. And they don't just send appointment text, they send healthy messages about healthy eating, about exercising, all kinds of prompts, trying to improve people's general health, not just thinking about medical conditions. There's lots more video links to service user homes. And we've talked about robotic assistants a little bit over the last couple of days. And a really interesting recent study showed that 26% of Europeans on average across the 28 member states are actually comfortable with the idea of having a robot providing services and companionship to them if they became infirm or as they aged. So what is digital health literacy? We've known for a long time, since 1999, that there's been long-standing recognition that the cognitive and social skills needed to access, understand and use health information is a prerequisite for empowering individuals to take control of their own health. But I believe in the 21st century that it's imperative that actually individuals develop their digital health literacy skills if they're going to be able to make full use of digital health information and the current and emerging e-health tools and services. Because as I've said, getting the apps approved is taking a long time, so people need to be able to evaluate the apps for themselves and make sense of the information that it gives them. So what are the barriers to digital health literacy? A recent survey across the EU showed that it varied by country, but between 50 and 62% of respondents felt they had limited digital health literacy. Barriers can be that they've got poor digital skills generally or limited access to the internet. There was a lack of confidence to search and evaluate the information, a lack of trust in the information that they found, a lack of confidence in actually then using that information and going to talk to healthcare professionals. Some people felt that the healthcare professionals wouldn't listen, and therefore it wasn't an even dynamic. And a recent study in the UK shows that if you look at this chart, that up to 54, pretty much everybody has access to the internet and has used it in the last month. When you get over into the 55 to 64, it goes down a little bit to 90%. But by the time you get to over 75 years of age, only 40% of people in that age group are regularly using the internet. And data shows that they are the people who are most in need of using these services. So if they're not accessing it and they don't have family or friends to do it for them, they're actually really limited in their ability to engage with health information and to develop their health literacy skills. So our project was called Discover. It was an EU project. There were nine partners, and we had 4 pilot sites in the UK, in Greece, in Spain, and the Netherlands. And it was aimed primarily at carers. We had over 650 participants. There were family carers, some paid carers. It was primarily focusing on family carers. And we also had older people themselves. And the age rate, they had to be over 18 to participate. But we had people up into their 90s, some of whom were familiar with using computers, and others we were introducing them to digital skills and health literacy for the first time. So it was a co-production endeavour. So we asked our carers and older people to help us develop a skills zone that would help them develop their skills. And they were very clear that what they wanted was to learn about the health conditions of either themselves or the people they were caring for. So we gave them links to all of the known websites that support people with different conditions like Alzheimer's Society, MenCap, etc. We also gave them tools to learn about the most common conditions across the EU, which is like dementia, COPD, heart disease, diabetes and stroke. We also introduced them to the idea of learning through serious games. So with a serious game, this was about reducing the risk of falls. And basically, you hover your mouse over the image and you find a hot spot, and it then tells you of the problems that could exacerbate the risk of falling. So, for example, in the middle of the room, you can see the rug is rucked up. When they clicked on that, it gave them advice about what you could do to improve the situation. It gave them further information, so it might tell you about exercises that you can do even if you're wheelchair bound, or you can exercise within your chair, or standing up holding something, which all helps improve your balance. if you don't like playing, and then it scored how you were doing and told you how you were progressing along. There's 14 hotspots, and it told you how many that you had found. And there were quizzes associated with all our learning. It was all bite-sized learning, and there were quizzes, self-assessment quizzes associated with every piece. So after you clicked on a hotspot here and learnt about that risk and how you could ameliorate it, you then answered a self-assessment quiz. If you didn't like playing the game, you could go to this other button and it showed you all the hotspots, and you could just click on them and work through it that way. But actually what we found was older people actually like playing serious games. They thought it was good fun, a nice way to learn. And a lot of people had told us before we started doing this that they wouldn't want to engage, and that wasn't the case. So we had interviews, we'd had questionnaires, and we also had more in-depth interviews. And the information they were saying was that it was really important to find and be able to evaluate high-quality information. As one carer in Spain said, sometimes what you find is deceptive, and actually it can really scare you and make you worried about the health of the person that you're looking for, when actually that's not accurate. And another carer in the UK was saying that she didn't know enough about strokes when her husband had a stroke, and what she'd learned through being through our education programme was that actually if he'd been transferred to a stroke unit, he would have had better outcomes and would have been able to come home sooner. But she didn't know, and none of the healthcare professionals had talked to her about this as being an option. With preventing falls, people appreciated learning about the specific exercises, and they used the information that they had learned. So they were doing exercises with the people they were caring for. One of them in Greece had changed, well, quite a few, this is just one quote, as an example, were changing the living space to make it safer for the persons. They were less likely to fall. And we had quite a few people in the oldest age group where they were what we termed reciprocal carers. So they were not living together, they were friends, but they both had various medical conditions, but they regarded themselves as carers for each other. But primarily they were friends, and it was the friendship that made them help each other. And one of them was saying it was great to know what to do yourself if you fall, that, you know, you get help and you get your friend to come round. And they felt much more reassured having that information than they had done living on their own previously, especially as a lot of them were in their late 80s and 90s. We also talked about how to cope with challenging behaviour. A lot of our carers were caring for relatives or in residential care, people with dementia. And they were now much more understanding of the change of behaviour and how you need to stay calm and how you can actually interact with somebody without exacerbating the challenging behaviour. And it was surprising that people in care homes didn't feel they were getting the training that they needed and were finding working through the information we were giving them and being able to evaluate things for themselves was really helpful. And also, one lady was saying that her son had had a stroke, but that had really changed his behaviour. And through working through these and learning about this, she felt more able to cope, and she had a better relationship with her son. It was also really important to think about how technologies can aid independence. Things like automatic pill boxes. It's surprising how little information there really is on how to acquire these different aids. So we gave them keywords. We gave them examples of what might be the problem. You might be looking for somebody, you might be worried your relative's not taking their medication. And so we said, if that's the problem, there are these solutions, and these are the keywords to be able to search on the internet to find solutions. And one young adult carer wanted to go to university, but her mother could never be left because of her epilepsy. And she found that the bed sensor gave which she'd never heard of, she was really impressed with and felt that gave her a chance to really help support her mum and meant that she could then stay away overnight, which, since her mum had developed epilepsy, she'd never been able to do. We also we had stakeholders involved in the project, and we asked them if improving carers and older people's digital health literacy was making any difference. And they were saying it really improved the quality of the consultations that they had. They felt there was much better understanding of the condition and how they might be able to tailor improvements to that individual. And also, quite often, the carers were pleased to tell the consultants why they felt they'd been learning, why they'd had this opportunity, and how they felt more confident. So we found that was really positive as well. So from our quantitative data, we were able to show that they had improved their knowledge about the services that were available to them and to the people they were caring for. They were more able to search for websites that gave them relevant information. They were more confident to use it. They felt more confident, those who wanted to look at assisted technologies, they had more understanding of the range that were available. And they'd very much improved their knowledge around the health conditions of either themselves or the person they were caring for. And that we also had forums, and they felt so they were able to talk to each other, and they were feeling much more supported and much less isolated, especially people who were caring for somebody who was really quite housebound, and it can be very isolating, and they found that the sense of community they were getting was also really important for reducing loneliness. We also asked them about how they felt in themselves about the World Health Organization 5 questions. Do you feel cheerful and good spirits? Do you feel calm and relaxed? How often do you feel active and vigorous when you get up in the morning? Do you feel fresh and rested, or really tired and not feeling that you've had a good night's sleep? And are you able to fill your daily life with things that interest you? And we found that there was a marked improvement from when they started joining the project to when they answered the participation questionnaire for the family carers and for the care workers. It didn't improve those things, but what it did do was improve the negative aspects. So we had fewer of them reporting that they didn't feel that they felt they didn't feel these things. So we thought that was really very valuable too, and showed they were getting more than just learning about digital health literacy. The other thing that was really interesting is that before they started the project in the questionnaire, less than 25% of carers and care workers felt the people they cared for would benefit from developing digital skills and their own health literacy. But after they'd participated in the project, 85% of them would recommend that digital health literacy is actually really important for the people they were caring for, not just for themselves. So the challenges that we face is that we need to enhance much more the digital skills and the digital health literacy skills of family carers, care workers and cared for people. We need to do more to raise the awareness of the opportunities arising from telehealth and telecare, and from just being online, that you don't have access to a lot of the things that are more reasonably priced if you don't have access online. And we know that a lot of carers are actually living on the poverty line because a lot of them have to give up their work to go into full-time caring. And the benefits that you get are very, very minimal. There's also still, in the older generations, a risk of using, a fear of using computers. They still think they're difficult to use. They're worried about identity theft and fraud, and they're very concerned that if they get a tablet or a laptop, there's no technical support. So when they don't know what to do or things go wrong, it's very difficult to get help. They also worry that there's a stigma of using assisted devices, identifying you as old, and that there can be a loss of privacy and feeling that you're under surveillance. So we still have a big mismatch between older people and the technologies that are available for them. So I think it's really important that we increase the opportunities and the programmes to improve digital health literacy, and it needs to be based primarily on health conditions. There's quite a lot of data showing that people only go along to learn about either diabetes because they have diabetes or heart failure or stroke. But you can embed into that those skills to enable them to actually look at comorbidities, and as things change, to develop that understanding for themselves. We also need to improve a seamless linking between our care workers, our care services, and the information and our online communities, because at the moment it's all quite disparate, and people find it reported they found it very difficult to actually find the information they wanted in a timely fashion, because often this is crisis management, that suddenly something happens to them or their relative or friend, and they need to find the information now, and it is really difficult. And then they don't know how to evaluate the information that they do find. We also need to make sure that care home residents are enabled to use digital devices. Often there aren't any devices in care homes, and if there are, there's nobody in the staff who knows how to really help facilitate using them. And I think the other thing that's quite dear to my heart is we really do need to accelerate the approval of apps, because I think a lot of people are moving to using them. I've had some really interesting talks about them, but how do we know that they are really reliable and giving the information that's needed to both the individuals themselves, their relatives and carers, and our healthcare professionals? So thank you very much for listening. I'm sorry I'm a bit croaky this morning. This is just a picture of our various carers working, learning and discussing things across the 4 countries. So thank you very much.
Does anybody have any questions for Verina?
Hi, thank you for that. That's really fascinating. I'm just wondering, is the system going to be live for the people to use after the project, or what's going to happen, kind of what's happening next?
Yeah. It's been live up until about 2 months ago, and we're trying to find out what the problem has been. But I've also got all of the platform has been wrapped into a web package, and I haven't had chance to look at how we can facilitate that. But we think the platform is stored in Spain, and the company that was storing it has been taken over. So we're just trying to work out what's happened in that takeover. But people up until a couple of months ago were still actively using it because it's free. It's just a digital resource that has no. Once you log in yourself, and then it's freely accessible. But all the materials we have as this web package that we should be able to also set up somewhere else if we can't get Spain activated again.
Any more questions? I'd like to invite our second speaker, Parvathy. Parvathy is a health and wellbeing PRA PhD student here at the OU. And Parvathy, are you year 2?
Just started.
Just
third
started,
year.
so my apologies.
Third year.
And Parvathy works with colleagues both in the faculty in Wales and in STEM. And last year, Parvathy and I were at an event at the University of Oxford, which was for early career researchers. So Parvathy had the opportunity to present some of her work and gain feedback. So I'd like to introduce you to Parvathy. Thank you, Parvathy.
Good morning, everyone. My name is Parvathy Harilal. I am a PhD student here at the Open University. Today I'm going to talk to you about my PhD research. The topic is digital health literacy for people aged 60 and above, investigating the motivations, challenges, and experiences. So in today's presentation, I'll initially talk to you about the context of my study. Then I'll talk about the aim of my research and research questions, methodology, and the methods that I'll be using. And after that, I'll discuss the initial, very initial and indicative results that I have. I don't have a final result yet. And then I'll talk about the contributions that I'm hoping to make. So first of all, the context. As we all know, the world population is aging at a very fast rate. According to the United Nations records, the people aged 60 and above in the world is about to become 21% of the total population by 2050, compared to 8 and 10 percentages in the year 1950 and 2000. Similar is the case in the UK context. According to the Office of National Statistics, the percentage of people aged 65 and over in the UK is going to become 24.3% by 2037, compared to 15.8 and 17.5 in years 1992 and 2014 respectively. This changing demographic provides us with different opportunities, both for the society as well as for the individual. For instance, the experience and expertise they can bring to the society, the roles they can play in the family and in caring as well. But all these opportunities does not come without challenges. One of the most important challenge would be that aging can potentially be associated with different health issues, and this can put increased demand on the healthcare facilities. For instance, every day on the newspaper we hear about the issues faced by NHS. One way to address this issue is by facilitating self-management of health by older people. By this self-management, everybody would be able to take responsibility in the day-to-day management of their own health. Health literacy can facilitate self-management of health and thereby help avoid medical emergencies. There are many definitions for health literacy in the literature. The one I am following is the WHO definition, which is the cognitive and social skills which determine the motivation and ability of individuals to gain access to understand, use information in ways which promote and maintain good health. Digital technologies can be very advantageous in facilitating health literacy. For instance, you can access health information online from the comfort of your home without going to a library or talking to the GP. Digital health literacy is defined as the ability to seek, find, understand, and appraise health information from electronic sources and apply the knowledge gained to addressing or solving the health problem. The electronic resources here could be health websites, health blogs, mobile apps, wearable devices, even YouTube videos, social media, online courses, and so on. Basically, anything that can provide health literacy through digital means. There are a lot of challenges associated with designing digital resources for older people. Some of them being accessibility issues and trust issues. It's not very easy for many older people to trust the information they find online, and also to use facilities like online banking. There is a need for further research in this area because there is still lack of acceptance of technology among people aged 60 and above, although some people do accept technology and are very enthusiastic about technology, but there are still a lot of people who don't. And there is a lack of human technology blended support, which means just providing information online is not enough. There has to be some kind of human interaction and somebody to help them if they need help. And there is, in the field of human-computer interaction, there is a lack of theory-based interventions or different theories being used, and there is no real idea of which theory is the best, or not everyone is following theoretical based approach. The aim of my research is to understand what older people want from digital technologies so that they can gain and sustain health literacy skills to manage their own health. It is very important to understand the user in their daily life context to understand to achieve this aim. I have 4 research questions for the study, and they are in the main areas of motivation, challenges, offline influences, and self-management. The first question is, what motivates older people to engage with digital health literacy resources? What are the challenges older people face when accessing and using digital health literacy resources? How is digital health literacy in older people influenced by related offline interactions? By offline interactions, I mean any interaction they have with another person about health-related needs, or the health information they gain from other resources like books or the leaflets they receive from hospitals. And the last question is, how does engaging with health information online translate into health management by older people? So my study is a mixed method study. The participants are people aged 60 and above living in the UK. The recruitment, I am currently halfway through my data collection. So I have finished the first 2 stages of data collection, and I have 1 more left. So the first stage was a survey. And this was publicized online and offline through social media, and also through different websites like Open University website, Age UK Milton Keynes website, and also it was published on a University of Third Age website as well. And based on the initial analysis of this survey data, the participants for further stages of my study was recruited. The theoretical framework used for this study will be actor network theory. According to this theory, all actors that participate in an interaction shape the relationship, but in a reflexive way, and also that the interaction shape the nature of the actors recursively. The actors could be both human and non-human. For instance, the actors could be the person interacting with the health website, the laptop itself, the health website. If somebody is helping them to interact with the website, that can be an actor. Or if that person is helping another older person, then that can be an actor too. Thematic analysis will be used to analyze the data. So as I mentioned earlier, there are 3 methods. The first one is a survey, then the next one is semi-structured interviews, and then usability evaluations. So the survey was publicized online. The survey was both available online and offline. The offline version, which is the printed version, was necessary because I wanted to get opinion from those participants who do not use health-related online resources for managing their health, or those people who have used it before but decided not to use anymore for any reason. So around 25 printed surveys were given to Age UK Milton Keynes office, and some of them were filled in. So the survey took around 10 minutes to complete, and there were questions to collect background information such as age, gender, educational information, etc. And also I have measured the digital health literacy of the participants using eHealth's scale. And there were also questions to capture motivations, challenges, and experiences to broadly address the research questions. And another main aim of the survey was to help with further recruitment. I was hoping if I get a lot of people to participate in the survey, which is more easy to publicize, so then I would be able to have a better diversity of participants in my interview and in my usability evaluations. So the survey was piloted with 5 participants, and after the necessary changes were made, it was open for 4 months, and 150 participants filled the survey, of which only 11 were the offline survey participants. So I did not have do an in-depth analysis of the survey yet for answering the research questions. I will be doing that after I finish all my data collection. So as intended, the initial survey analysis helped in recruiting participants for interviews and usability evaluation, and also helped prepare questions for the interview and the usability evaluation. But there were some issues regarding the survey. One thing I would like to discuss is the sampling issues. There was less diversity than anticipated in the survey. One of the main aim of the survey was to ensure that I have a very diverse set of participants, but the survey had about 57% of people having graduate or above degree, and most of them were female, and most of them were in the age range of 60 to 69, which is younger. And also, the offline survey did not give the results as I expected. I was hoping the survey would be filled by people who doesn't use internet much, but it was still filled in by the people who use internet. There were a couple who did not use internet at all, but they were not interested in participating in any further stages of the study, so I couldn't follow up to understand why they don't use internet for health. So in the interview, to address this to some extent, I have added questions to see if my participants know anyone who doesn't use internet for health-related use at all, and if they have any experience teaching them or talking to them about this and what that was. I have got some responses regarding that. So the next stage was semi-structured interviews. The recruitment was based on the initial survey analysis, and my aim was to capture life experience stories, for instance, their experience of dealing with a health condition like diabetes or a health condition of their loved ones. So I was hoping with these I can answer the research questions on motivation, offline influences, and self-management. So I did 25 interviews. Each of them were around 1 hour long. And the interviews had basically mainly 3 sections of questions. The first question was about their general internet usage. For instance, what they use the internet for, what kind of gadgets they use, how did they start using the internet, and did they get any help, or have they helped anyone to learn how to use internet, these kind of questions. And the next section was about their health-related internet usage, about how they rate the quality of the information they find online on health, and how trustworthy they find this information, and such questions. And the final section was about sharing health-related information with others, for example, whether they will share it with their family, friends, and I was also interested whether they will share the information with their GPs, and if they share the information with their GP, how the GPs would react to this information sharing. So I am still in the process of transcribing my data. So I don't have any results as such, but I have some quotes here to give you an idea of what the results might be. So the first person I'm going to talk about is a male participant who was aged above 80, and he's retired. When asked about his experiences of using internet, he talked about how the internet has got so much easier now compared to the past, even though he still feels that he has to train his brain to get the technology to work. that is one thing many other people talked about as well, because they mentioned that they did not grow up with technology, unlike their grandchildren who can do everything on their iPad. So it is different for them. So when asked about health-related internet usage, he said, reading about health doesn't make me healthy, but it does take the anxiety away. And he also mentioned that he discusses the information he finds online to his GP and his consultants, and they engage with him in a very good conversation, and this has helped him looking online has helped him ask good questions, the right questions, and it helps him communicate better with the GP, and that has helped him have a better knowledge of his own condition. And then he also added that too much information is not very good. It can be dangerous and frightening. However, when he mentioned that, he said it is for others, not for him, because he considers himself to be an expert, and he thinks he knows everything he needs to know about his health condition. But he understands that there can be very scary information on the internet. The next participant is female, aged 60 and above, and she is still working part-time. She has retired and still keep working. Again, she considered herself to be a technologically competent person, and she has shared her experiences of teaching other elderly, older than her people in her friend circle and family. And she says that teaching them to use internet was hard and sometimes quite frustrating. They would ask things like, I don't want it to remember things about me. And also, if the computer is asking for confirmation, they always hit the no. For instance, if computer is asking, are you sure you want to log off? They say no, because if they ask again, that means I'm going to do something wrong. So she had to explain it again and again to them. But she feels that once these people find there is some usefulness for them in this, they are interested and they want to learn. For instance, if they can talk to someone far away over Skype, to whom they cannot talk normally, they are happy and they are willing to learn. And she also shared her experience of being taught to use internet by younger people. For instance, her children, they are both in their 20s, and they would tell her, for goodness sakes, that's so easy, and how can you get this wrong? So she has shared both sides of experiences. And when asked about her health-related usage, she is very happy about her health-related internet usage, and she feels that she's capable of deciding what's good for her and what's not. And she even helps other people to understand more about their health condition. And again, the last statement is not for herself, it is for others. She says some people may not understand if there is bad information provided online. And there has to be some red wavy banner headline saying that take this with a pinch of salt. So the final section of my study is usability evaluation. I did not do this. I'm in the process of conducting usability evaluations. The recruitment was again based on the initial survey analysis. 8 to 10 participants will be involved. So each participant, the participants will not be asked to choose resource from a list provided. I'm sorry, I forgot to remove that. So what I'm doing now is I'm giving the participants a scenario where they have to find some sort of health information online to find out about a particular health condition, and I want to see how they do this, and this will be recorded. There will be another scenario where the participants will be asked to help a friend to learn how to use the internet for health-related needs. And while doing this task, they will talk to me about why they are clicking on one button and what they think about each resource, whether it is beneficial or it is not very good, and they explain why they think it's not very good. After the usability evaluation, there will be a post-evaluation questionnaire where they can talk about anything, any other advantages or disadvantages they have about these resources, and if they have any ideas on how to improve these resources to make it better for their own use. The reason why I'm doing this usability evaluation is to address the research question on challenges of using these resources. So the expected contributions that I'm hoping to make is to create a better understanding of what older people actually need from digital health literacy resources to gain and sustain health literacy skills, and to better understand how offline interactions affect digital health literacy. This is very important because our online life is not separate from our offline life, and to be able to interact with digital health literacy resources, it's important to get support from people if they need to. So I want to make an understanding of that. There will be design guidelines for more effective resources. And also I'm hoping this study will broaden the knowledge of the field of digital health literacy in general and in the context of population aging. So we discussed about the background of my research and the aim, and I talked about the methods, and I shared some of the results I have so far and the contributions that I'm hoping to make. And that's all. Thank you.
Thank you. Do we have questions for Parvathy? After September or at the event that we were at Oxford. Has anybody else who, I know Caroline and I and Verina have done work, and Charles, with older people and technology. Can anybody offer any advice or maybe possible solutions in regards to recruitment? Because we all have different experiences. Any advice, hints, tips? Melanie?
It takes a lot longer and it's a lot harder than you plan. Yeah, I think that's the reality.
Yeah. Caroline, you're...
Well, I was going to say, particular issue, of course, is getting people who aren't online, not digital, aren't interested.
Yeah.
That's, how you can do that in the context of a PhD is quite hard, I think, time-wise. Yeah. So a bit more sort of bright ideas.
And I think for us working with older adults and technology, we want those that actually do use the technology as opposed to those that don't. And yeah, Grant, do you have any thoughts?
Cast a wide net. Probably doesn't help that much, but cast a wide net. Try to get plugged into local sort of services and charities and people like that. So a lot of my work around dementia, places like dementia cafes can be useful. And then have a look at what local sort of organisations and networks are around in your area and try to make those contacts. But yeah, cast a wide net basically, I think. And as you've said, it's always takes longer and is always harder than you expect it to be.
And I think this year's, because there's quite a lot of members of the British Society of Gerontology in this room and at the conference this week. And I think our special interest group and your special interest group, Caroline, maybe we can try and generate some interest in recruitment for this study.
And simpler studies.
Yeah.
And one of the things that I've done in trying to reach hard to reach populations, not necessarily older people, but you can use your participants themselves. So after you've had an interview with them and they get a sense of you and what your study is about, it's perfectly okay to ask them if they know of other people who, and then they're facilitating that introduction in a way, which can also open some doors for you.
Okay, thank you.
Matt, nice to see you. Thank you. Matt's going to be our keynote later this morning, but Matt, you use technology in the community up in West Yorkshire. Have you had patients who have been a bit anxious about using technology, and it's through word of mouth that they said, oh, so-and-so's using it, can I use it? Or do you have any thoughts from your standpoint as a GP?
As a GP, I would say that what you need to do is actually contact your general practitioners. We are evolving. I'm hoping I'm going to entertain some people with how we're doing that later this morning. But we are evolving, and we will have groups of people who we know are engaging. I think the biggest challenge that we have at the moment is understanding how to translate our jargon-filled younger speak into things that older people actually understand. Then I have to say that I talk to my children and I haven't got a clue what they're saying. And so it is a very generational thing. And I think there is a bit of us having to understand how to break down that information into the language that people are using. But I think that's a challenge to the whole of digital enterprise, whether it be us in health or people in commerce. They need to understand that people read things in different ways.
And I think as well, the age groups that you've got in your study or want to recruit, I mean, it's spanning over 2 decades, which different experiences because of retirement work. You've got the 80-plus generation. They'll have completely different experiences. Some may be very open to using technology or do use technology, but some may not be as well. And I know with some literature there's very little published on those participants or studies that recruit 80 plus. They might have the odd one, but it's not written up. So trying to find the experiences as opposed to the baby boomers, I think is also difficult. Verina, do you have any thoughts and advice for Parvathy? Sorry.
Echoing the lady at the back, we did in our project quite a lot of snowballing where we asked participants to recommend other people who they thought might like to be involved. We also used carer centres because we did a lot of flyers, paper flyers that we could sort of, I'd say, litter around the place because that's the way to do it. You need to have it. It's easily accessible. Nobody has to ask anybody about it. And we put posters up. We had small posters that we put around, and that seemed that more what I call casual approach, I think worked better than when we were trying to do it via some of the... It was gatekeeper driven in that we asked their permission to put the posters up and to put the flyers around. But that seemed to do better than doing just purely online.
Okay.
So I think that would be worth trying.
Thank you.
Can you remind me again what the gender ratio, have you got more women at the moment
More women
than men?
Yeah.
That's interesting, because sometimes it's more men than women or...
No, because it's about health.
Yeah, which is
It's
another
about
angle.
balance, it's about- yeah.
Because I was going to also suggest you could approach the Women's Institute, because there's a lot in this area as well as across England and Wales. But that's sort of... But I'm thinking of word of mouth with what Terry Lynn has just said. If a member or members have got husbands, partners, they could spread that way.
Yeah.
And libraries as well. Maybe put posters and maybe offer to go and give presentations at other age centres.
You'd say that part of the offsetting of that is the asking of the people doing the usability tests to talk about people that they're working with a lot. So it's a sort of slightly proxy, but at least trying to get some of that information back.
Yeah. I mean, we've still got a fair bit until the break. So, Charles, you've done a lot of work with technology and ageing down in Swansea. What are your thoughts, experiences?
In terms of In terms of recruiting, I would echo what Caroline was saying earlier on. Alison and I were talking about it yesterday. We tend to get the low-hanging fruit, if you like, so easily each time. And sometimes they're not the ones that you really, you want a nice range of experiences and backgrounds, particularly when you're doing qualitative stuff as well and in-depth stuff like we're quite often doing. You want, a real range of backgrounds to come to the fore. And sometimes it's hard to reach those kind of people. I mean, we've got a database at Swansea of 600 older people that we've contacted on projects at one time or other. And then we get them to sign up to the database to say that, that they're happy to take part or to be contacted at least for further research. So that's quite a useful thing to do again. But again, I do think that most of those are quite middle class, white, and articulate. And I mean, there are a few, but then we tend to overuse those few, and then they get bored or sometimes quite cross. And so it's hard to manage them all in a nice kind of way. But we do keep in contact with that 600 people by sending out newsletters and just updating them with stuff, so they feel part of the research group a little bit. But I am, acutely aware that we've not got a good representation, I think, of people. So I don't know what else I could offer, but it is hard work and takes loads of effort to get the people that you want.
Thank you.
Have you actually thought about partnering with general practice? Because we are contacting our patients all the time now with text. How many of you have had an appointment with the dentist or the doctor recently, and you'll get your reminder with your text? We are obsessed with getting numbers so we can text people. I think it's interesting that you're talking about the gender split, because actually when I talk to my patients about texting and Skyping and so on, it's invariably the lady of the couple who seems to understand that better, because they're using it to keep in touch with the family. My grumpy Yorkshiremen don't care. So I do think that's interesting. But as we're starting to branch out into a digital front end of general practice, I think it would be interesting to see how you can push that. Something I'm not going to talk about, but I'm doing a lot in practice, and I was thinking about it on the train that I should have put it in, is how do you extend the 600 seconds of the consultation? Because that's all I have with a patient. And if you're 80 with bad knees, I could lose easily 100 to 200 seconds with you getting out the waiting room. And the way I'm doing it is I'm SMS texting hyperlinks to all kinds of things. Usually the charities I have associations with, but saying to people, I'm going to send you more information. And it is interesting how many of them will say on the next consultation, I found that really useful, what you've sent me. So it's just making me do it more. But it'd be interesting to know how that is actually being received, because I'm a bit random and not studied. But I would suspect you could find a forward-thinking GP practice that would engage with you. We would.
Thank you.
Thanks. Just a couple more thoughts from what people were saying. If you're looking for men in sheds might be a good place to go and talk to as well, if there is some locally here. And then I was thinking, we've got a PhD student who's doing research on carers of people with dementia within the Southeast Asian community in Manchester. And she's built relationships with, I think, 2 community groups where she's going there, she's done presentations, she's going to the carers group, she's kind of making herself visible and useful for the group. It's taking a lot of work for her, but it is also being really useful in terms of getting research participants. So that's definitely one option, either for you or for you guys as a centre to kind of build the links with local groups.
And I know health literacy and digital health literacy, it's such a popular area that's, 5 years ago there was maybe the odd person researching it, but now it's becoming more common. Parvathy, with your work, sorry, you're getting grilled, aren't you? With your work and the literature reading around it, have you seen much published work looking at younger generations or other older generations? What's going on in the literature?
There are things published on both younger and older, but I haven't gone deep into the younger generation literature because mine is.
Of course.
Yeah, but there are so many general, not focusing on a particular age group. There are so many research. There are so many papers on this topic.
Because I think, you know, I remember 2 years ago, I was in the job centre in Pontefract, and I was waiting for an appointment, and there was a couple came in, late 20s, early 30s, and the woman had to fill in a booklet, and she was talking to a gentleman on the table who she knew, and next thing is I heard her say, "Oh, I can't be bothered with this, I'm going outside." And I kind of just observed, and I realised when her partner started to complete the booklet, they may have been literacy skills problems. And she came back in, and her partner still continued. And I thought, you know, we throughout now or in the past or in the future, we all have documentation to fill in, and it's not the easiest, regardless of how qualified one may be. And I just wonder, you know, I haven't heard much in the media, newspapers about the importance of health literacy, digital health literacy. And I wonder from the standpoint of you, Matthew, who see the community on a daily basis, different age groups, socioeconomic, what's your thoughts on this digital health literacy? Is it prevalent? Do you see it from a GP standpoint?
Health illiteracy, you can rub out the digital. Health illiteracy is massive. I think it would be a very interesting study to get a group of people into a room and point to an outline of a body of where their heart is, their lungs are, and their kidneys are. You know, we really are starting from a very low point. I think Charles made a comment there about the fact that you do end up with the already literate group, and are trying to develop that further. The idea that you saw a couple in Pontefract and one of them was illiterate, come to Bradford and you'll find that's even commoner. And we have people who are illiterate in both English and their first language. So that's a real challenge when it comes to educating people about their health. And we're about to get a big issue, which I will talk about, which is around the cardiovascular agenda, where actually there's so much lifestyle in there that the illiteracy of not understanding even the basics of diet are going to stymie us at the first hurdle. So no, I think it's a major issue. It should be taught in schools much better. But then again, so should reading and writing. So.
Yeah. I mean, yeah, you're right in so much as in the Bradford area, different communities, and it's up and down the country and overseas as well. What was interesting, and some of you may have been in the presentation earlier this week, was Mimi Tatlow-Golden talking about the advertising literacy aimed at young kids, food advertising. And when in that session I mentioned about, you know, it's another literacy, you know, we have the health literacy, etc. We've now got the advertising. And I just thought, you know, we know, Matthew just mentioned about healthy eating, diet. We know that the sugar tax is coming. And I just wonder, you know, all this work is going on, but nothing seems to be filtered through. As you say, stuff should be taught in schools. Why isn't this being taught? You know, what do you hope with the guidelines? Obviously, it's going to be based on your results and experiences, but what do you hope to take in the future with your work?
Yeah, as Verina's presentation, she was talking about NHS having to approve more apps. So these kind of things, even small, and GPs advising patients to directing them to good, reliable websites or resources. That.
Absolutely. There is now, of course, a website you can go to showing NHS approved apps and such like. My big problem with it is still the evidence base is locked away from me. And doctors are constantly criticised in the use of pharmacological agents and not truly understanding the evidence. When I'm recommending a health app, I would like to be able to see the evidence. And of course, we're not going to be talking about a 20,000 participant randomised control trial. It's always going to be a smaller data set, and I accept that. But I want to see it. And I find that a lot of the providers are not quite as open with their data as I would like them to be. I know we could argue about Big Pharma as well, but this is an emerging technology, and it would be nice to see them change the rules about holding back negative stuff, promoting and badly promoting borderline stuff. But for me as a doctor, I want to see the evidence. It's not good enough for me for somebody in a back office of the NHS to have said they think this is okay, because I don't know who that is. I want to be able to read the documents myself.
Matthew, a question, and this may be a bit of a political, dicey question, but you as a GP, your colleagues in the area up north and across the country, what are your thoughts regarding health literacy? You know, you want to see this evidence and not from somebody in a back office. Is that echoing across the sector?
I think the evidence base, more and more doctors, I mean, I'm kind of like the older end of the evidence-based generation, I would argue. So, of course, there's less doctors ahead of me than there used to be, older than me than they used to be. And they were in a little bit more of the consultant says, therefore it's true. I've grown up in it must be proved. And, of course, we've just seen today the fact that the BMJ's published that oil in the bath doesn't help eczema, but it's always been logically thought it did. So, you know, the evidence is evolving, and I think I'm the older end of the generation that wants to see that. As regards health literacy, though, I would, in my professional, I've been a GP for 20 years, and I think it's falling. And now we could argue the reasons for that, whether that's due to the breakdown of the family unit or whatever. But I am seeing people come with more and more minor ailments because they just don't know. They are scared and they just don't know what to do. And then we're trying to educate them, but there's only 60,000 GPs across the country and 64 million people, so it will take us a long time. But if we're going to control the access to general practice, which we have to, because we are limited, we have to educate the population to look after themselves better. And I don't mean good diet, I mean how they treat themselves with minor ailments. I do mean good diet as well, obviously, but how they deal with minor ailments. You know, you don't need to phone the doctor if you've just pulled your back and you haven't taken any paracetamol.
I find that actually really interesting. You know, sort of your observation, because in a way you might almost expect the opposite, that in the profusion of information that's now available online, people should be able to figure that out for themselves, but maybe it's all become just so overwhelming that people get lost in trying to find that, and they just need that, you know, reassurance.
The only website I recommend to my patients is routinely the NHS choices. I send them all to NHS because I think it's the best. No, but it's NHS branded, and it means that everybody's going to say that.
Verina, you wanted to say something?
I just wanted to echo your point about it might be about family, not necessarily about family breakup, but about family dispersal, because it's only anecdotal evidence, but I have several friends who work in as receptionists in GP surgeries, and they say that what they've noticed over the last few years is that in the village halls near where the surgeries are, there's a Tuesday afternoon mums and toddlers group, and after that meeting, the young mums come in and are asking questions which normally you go to your own mum or your auntie to ask about minor ailments, and they come in and ask the receptionist, and they don't want to see the doctor. They just want a bit of reassurance that this little rash or whatever is not a problem. And they've been saying that they think that would make an interesting study, is that you haven't got that older family often nearby to ask those questions, and as a young parent you haven't seen it before. And it probably is okay, but you just want that little bit of reassurance. So I think that is something that is actually affecting basic health literacy, because perhaps it's been more passed down the generations within families rather than being something that you learn, you know, from a school setting. I think that...
I agree completely. I think Mumsnet, when it started, was incredibly useful for that. But I think it's become overcomplicated now and it's scaring people away. It's not just that blog site where you put your question and a few months answer. It's become a little bit more intimidating. But early on, it was fantastic for that.
Oh, that's interesting.
We've got our refreshment break at 2:45. So we've still got some more time for any more questions or discussion.
I've just got a couple of comments about a couple of things. I'm not a researcher, so I apologise if some of it's the obvious or anything. But a couple of things when we're talking about lifestyle. I think one of the things is everything seems to be talked about in isolation, a balanced diet or doing more exercise and things. And there isn't enough kind of collaboration about a balanced lifestyle or what that may be. You know, people are still going to have a sugary drink probably, realistically. But it's like, it's the extreme, isn't it? It's like, that's awful, that's bad. And then people are like, well, I'm still going to do it anyway. But it's like, well, if you have this, what does this mean? And I know they've started to try and do that a bit more with some of the Change for Life schemes. But I think there's not really enough education around about a balanced lifestyle in general in terms of exercise, activity, diet, sleep, all these things, and cohesion and how they affect your health and well-being overall. And then also another comment, just thinking about the recruitment. Have you thought about talking more directly with some secondary care providers, maybe where they're doing falls prevention rehabilitation groups or cardiac groups where they might be a slightly older age group? Because we've done work with falls prevention and rehabilitation groups, and that they're so receptive, and the teams there are more than happy to kind of share, and everyone's really been really engaging when we've done work with them. So just a couple of thoughts.
Thank you. I haven't done that, but it would have been a good thing to do. But this, I was hoping I will get all the participants through survey and get a good diverse participants from the survey. And survey was around 4 months. It ran around 4 months long, and I don't think I can go back into recruitment at this stage. So.
Just to make a couple of different points. One, to throw a slight spanner in the works regarding the talk about recruitment, and particularly recruiting through NHS settings, is one of the things that we as social researchers have to think about is if you can get access to those settings, it can be really good in terms of getting access to populations. But the hurdles that we have to go through in order to get access to those settings can be prohibitive. You know, if you're doing a clinical trial, then you've no choice. But getting through NHS ethics committee procedures, then going through NHS R&D procedures, that's 6-7 months of a project. And often, and I find this myself in a lot of our work, we actually end up designing research studies that actively bypass the NHS because it's just so time-consuming and difficult to actually get into those services. Even when you find, a forward-thinking GP practice or memory clinic or whatever that's willing to help, and when you get into them, it can be great. And it's a really good way of accessing people, but actually getting into those services can be tricky, particularly for social researchers that don't necessarily have those links already. And the second thing I wanted to mention about sort of the guidance and certainly the point that it's all taken in isolation is very true. There's also, I think, a perception amongst certain parts of the general public, let's say, about just how achievable some of these guidance is. So, for example, 5 fruit and veg a day is very difficult for a lot of people and families to achieve, whether that's due to health literacy, whether it's due to things like social inequalities, and that's important to remember that when we're talking about health and health literacy, health behaviours, general health is just how far social inequalities around class, around income, poverty, etc., completely shape all these issues around how people can access good health, basically. And then another point just to make as well is around some of the messages that come through health services that can be very contradictory at times. We know that the evidence base is always changing and always moving, but amongst the general public that can create a certain level of confusion. Who's right? Well, they're telling me to do this one week and now they're telling me to do something else the next week. Why should I listen? And also a sense of just how achievable some of them are. So, for example, guidance to do 150 minutes of moderate exercise a week. Having done this sort of thing in the past, I know that level of exercise is enough exercise for you to be able to do a half marathon. It's quite a lot in a lot of people's eyes, and suddenly many people will think, well, I can't possibly achieve that, so I'll not bother. So there are questions about exactly when we create these guidelines about what people should do. To put it bluntly, is it grounded in the reality of a lot of people's lives? Is a good point. So I'll leave it there. I think I've thrown a lot in there, but yeah.
Just to agree with that, I think entirely that we're quite good at talking about all of this kind of thing, but the bit that's missing is understanding how to do the behaviour change bit, which I still think has a very poor evidence base. We still tend to think that, it's almost like voodoo or magic, we can change people's behaviour. And I still think we tend to do things to people rather than with people, even though when we're saying we're doing it with them. And that's not surprising when a GP only gets, 600 seconds? How can you build up a relationship with a person? And, I've got friends who are GPs and they went into it so they could build up relationships with families and know people over time, so you get to know how best to help them with their lifestyle and their behaviour. But that's all gone and disappeared. And I still don't think, I've got friends who work in behaviour change stuff in universities, and the evidence base is not great for, how we go about doing that kind of thing, and over-reliance on nudge and things like that has not helped on that front. So we can have all the evidence in the world that certain things might work, but it's how we encourage others to do that. And, where we build digital stuff into that, we still don't quite know the best places to do that. And also Grant, you're spot on about, the difficulty of accessing NHS settings for qualitative research sometimes, or even doing survey research where we've got to go through the same rigmarole as if we're doing a pharmacological sort of trial, and the misunderstandings and illiteracy of NHS ethics boards sometimes with regards to qualitative research and what that actually means and does. There are when you find a good one, it's great, but then we tend to overuse them again and again. But it does mean that we're hitting low-hanging fruit, or we're not going for those difficult groups sometimes because it's too hard to reach. So yeah, I totally agree with those points.
Matthew, do you have comments on NHS ethical? I mean, we are, as researchers, we know that ethics needs to be there, and both Grant and Charles, and we've all probably had our own personal experience of ethics boards. I kind of wonder, and I have to phrase this, I kind of wonder those that sit on the respective committees, be it in universities, NHS, CCG trusts, etc., when they see all these applications coming in, apart from the length it takes of time to complete, but do those people who volunteer onto those boards, do they actually have maybe the knowledge or the experience to kind of decide this is a good project, this should be granted ethics in this area or not? It's just a thought. I'm just like Grant and Charles, and because sometimes it can take a minimum 3 months and 18 months for NHS ethics, but universities, different boards sit at different times and not as frequent as others. So I just wonder, just a thought.
Just to comment, the group local to me, Robbie Foy is our local professor of primary care, and of course his main interest is in behavioural change. And so I think long before I arrived getting interested in this, he had already beaten our ethics committee into shape, should we say. And so for that kind of thing, I do find it actually quite receptive, but I would definitely suggest that's because we've had a very powerful and vocal advocate locally who's pushed them in that direction.
I would say they're a lot better than they used to be.
I'd say they're a lot better than they used to be, but a lot of it's not even so much really the committee as much as the procedure. You know, it's this 50, 60-page form, you know, that takes several, you know, probably 10, 15,000 words worth of text in there to complete with a lot of repetition. And then once that's done, you have to go through different NHS R&D. Might have changed, the system might have changed compared to when I last went through this, which was a few years ago, but and I'm in Scotland now, and there are differences between Scotland and England in terms of a lot of these things, but yeah, having to go through multiple NHS R&D boards, each one is different and has a different set of procedures and needs a different set of information. Sometimes particular as well if you're going across different countries, so England versus Scotland versus Wales. And it's all these kind of, it's less about kind of the education of the committee, although that can still be an issue. It's the paperwork, it's the admin basically. It's that often takes the just time. And when you've got a PhD is bad enough at 3 years, but if you've got a pot of funding for, you know, like a small 6-month evaluation, well, forget going through NHS because you've just not got time. You know, it'll take you, you know, minimum 3 months, as you say, to get through that process, and then you've got to do your data collection, your analysis, your writing up, etc., etc. So it's just, you know, for a lot of these kind of studies, it's just not practical. And as I've said, we seem to spend a lot of time trying to find ways around that instead of actually using this, you know, if we can get access to it, this fantastic resource. Because as I say, once you're in, it's brilliant. You know, it can be brilliant. You can sit in clinics. You can even, in some cases, sit in on consultations, speak to people straight after their consultation, and you know, be sorted in terms of recruitment. But and as well as getting access to some of those harder to reach groups, because everyone needs to see their GP at some point. It's, as I say, it's just the procedure for getting in there.
We don't spread that.
Thank you, Grant. If there's no more questions or comments, refreshments will be served downstairs, just underneath the staircase, in the next 5 minutes. Thank you, Parvathy. Thank you, Verina.